right, so we are back. Thank you all who decided to return. We're going to start the first Nclex review. I don't think that I'm going to break things down as to this section, or this section as far as answering questions, because the Nclex isn't really designed to do that. They're just going to throw different questions to you based off of what they feel and based off of how the questions generate. They're not going to say we're going to do this body system or this safety measure or this IV fluid. That's not how they do things. They pretty much just throw questions at you and throw questions to you. So we'll just go ahead and do it that way. And that way we'll be able to kind of be able to attack the questions as they come and as they approach. All right, so we're going to delve into the first question. The first question says, when you are monitoring your client who is now started on an intravenous antibiotic for an infection, you notice that the client is exhibiting signs of anaphylaxis. What is your first priority intervention? Now, there's three important things that I want you to take away from this question before you even start to look at the answers. You're giving an intravenous antibiotic to a patient for an infection. Now, we already know, or we should know, that antibiotics can sometimes cause allergic reactions when patients have never been exposed to an antibiotic before, which brings us to anaphylaxis. Before you can even answer the question, you need to know what anaphylaxis is. What is anaphylaxis? Anaphylaxis is an allergic reaction that a patient has based on a medication that they've never been exposed to or a medication that they've never had before. And that's what this patient is showing. Now, what are signs and symptoms of anaphylaxis? Feeling lightheaded or faint, breathing difficulties such as fast or shallow breathing or wheezing, a fast heartbeat, clammy skin, confusion and anxiety, collapsing or losing consciousness. Now, are these very important side effects of anaphylaxis? Yes, because they can kill you. They compromise your ABCs, your airway, breathing, and circulation. Breathing difficulties, airway, fast heartbeat, circulation, airway, breathing. So your airways compromised, your breathing compromised, and your circulation is compromised just by the breathing difficulty, the fast shallow breathing, the wheezing, the fast heart rate, confusion and anxiety, collapsing or losing consciousness. That definitely affects all of your ABCs. So anaphylaxis is a very, very serious side effect to medications that need to be addressed immediately. Now, the next thing is, what is your first priority? First priority is a tricky type question, because first priority means a lot of times these answers are not incorrect. You have to find the best right choice. So what is the first thing you're going to do if your patient starts to experience signs and symptoms of anaphylaxis? Now, let's look at the answers. One option says stop the intravenous flow. Another option says slow down the intravenous flow. Another option says notify the doctor or begin CPR. Now, I want to start with CPR. I want to start with CPR because nowhere in this question does it say the patient lost consciousness. It just says the patient began to experience signs of anaphylaxis. So will we need to do CPR on a patient who hasn't passed out or hasn't lost consciousness? No. So it's safe to say that beginning CPR is not something that we need to do. Next is notify the doctor. We probably will need to notify the doctor at some point, but I'm not going to say that that's the right answer because I want to look at the other options as well. The next one is to slow down the intravenous flow or stop the intravenous fluid. We're either going to slow it down or we're going to stop it. I would probably say if my patient's showing signs of anaphylaxis and I know how serious anaphylaxis is, I'm probably going to stop it as opposed to slow it down. So I'm going to take away slow down, and I'm also going to take away begin CPR. The last two options that I have is stop the fluids or notify the doctor. If my patient is experiencing signs of anaphylaxis, do I want to stop the fluid or leave the patient alone to go call the doctor? Because you have to imagine, if you're going to call the doctor, that means you're leaving your patient alone while the fluids are flowing and the patient is having an allergic reaction. So would it be safe to say that we probably want to stop the fluids and then call the doctor? Yes. First thing you want to do if your patient is experiencing anaphylactic reaction, you want to stop the fluids immediately You want to check your patient. You want to assess your patient. You want to assess their vital signs. Make sure your patient is okay. Because if your patient passes out or loses consciousness, then we would need to do CPR. That's why CPR is there, because it's not a wrong answer. It's just something that we don't need to do in this instinct. Right now, we need to be stopping the fluids immediately. Whatever is causing this patient to have an anaphylactic response, you need to stop, which means stop the fluids. Then you want to go ahead and call the doctor. And if the patient were to pass out, you would do CPR. But the correct answer, your priority answer in this question, is to immediately stop the intravenous flow of the fluids. All right, so the next question, number 2, is as follows. The best way to determine whether or not a medication is compatible with a particular intravenous fluid is to what? So this question is asking, you have 2 medications. Let's just say you have 2 medications, and you don't know if these medications are compatible to either be hung together as IV antibiotics, or if they're pills, are they compatible to be taken at the same time? And you want to know. And you want to understand whether or not if it's something that you can actually give to your patient at the same time. How do you go about doing that as the nurse? Not as anybody else, but the nurse. What is your role as the nurse in determining whether or not if a medication is compatible with another drug? Let's look at the options. The first option is to mix a small amount of medication in a small amount of intravenous fluid and then examine this mixture for color changes. The next option is, which is B, refer to a compatibility chart. The next option, C, is call the doctor and ask if the medication is compatible with the particular intravenous fluid. And D asks whether or not if you should mix a small amount of medication in a small amount of intravenous fluid and then examine the mixture for any precipitates. Now let's look at this. Like I said before, 2 are always usually wrong. And in this question, I'm going to show you how to identify that. Usually, if you have 2 options that sound almost identical and you can't really choose or differentiate between the 2, they're usually the 2 that you're going to omit. And I'm going to show you. Look at A and look at D. The words are pretty much in sync. They're all the same. The only change is for color changes and for any precipitates. It literally says mix a small amount of the medication inside of a small amount of the intravenous fluid and then examine this mixture for any color changes or for any precipitates. The 2 answers sound identical. They just changed words at the end. And also, as an RN, is it your job to be at work mixing fluids together, IV fluids together, to see if they are compatible? You're not a scientist and you're not a pharmacist. Your only job as the RN is to find the orders that the doctor has put in for the patient and follow through with the orders. You're not mixing fluids, especially IV fluids, to see if there's a color change to know whether or not if it's safe enough for you to give to the patient. So it's safe to say A and D are not your option as the registered nurse. Is it someone else's job? Yes, but it's not your job. Now we're left with B and we're left with C. B says refer to a compatibility chart, and C says call the doctor and ask if the medication is compatible with the particular intravenous fluid. The same way that it's not your job to understand or to tell someone whether or not if a medication is compatible is the same way it's not the doctor's job. The doctor is not going to be able to tell you whether or not if a medication is compatible. The only thing the doctor is going to do is tell you to give the medication. You, like I said before, it is the job of the scientist, the manufacturer who made the medication, and maybe the pharmacist. It is not your job, nor is it the doctor's job to identify the compatibility or to tell someone whether or not if a medication is compatible to give to the patient. So the best option that's here is to refer to the compatibility chart. Every floor that you work on is either going to have a compatibility chart available by the Pyxis where the medications are, or the compatibility chart will be in some sort of a system that you do your charting in, some sort of a computer system that you can go and refer to see whether or not if the drugs are compatible. And a lot of times in the MAR, the computer system, when you go and click on to administer medications to your patients, before you even go to administer that medication, it'll automatically tell you in a toolbar, it'll either have a red stop sign or it'll tell you these two drugs are not compatible to take. So you either refer to a compatibility chart or something in your system where you're working at in the hospital that is going to quickly identify whether or not these medications are compatible to take. There's no one to really call to ask. And even if the pharmacist was an option, if a compatibility chart is on your floor, that is the first thing you're going to refer to before you call anybody. It's not your job as a nurse. It's not the doctor's job. And usually you're not going to call a pharmacist about compatibility when the resources are on the floor for you. So the answer is B, refer to the compatibility chart. All right, now we have question number 3, and question number 3 is, one of the primary purposes of a formal medication reconciliation is what? Medication reconciliation is the same thing we spoke about in a previous question. You want to know whether or not if medications can be given together, and whether or not if something's going to happen, if it's given, is it safe to give to the patient, or is it going to cause some sort of a reaction to the patient if you give medications together, or if the patient, how the patient is going to tolerate the medications that's given. So one of the primary purposes of formal medication reconciliation, making sure it's safe to administer, is A, prevent polypharmacy, B, conserve financial resources, C, prevent interactions, or D, prevent allergies. Now let's look at the answers. A says prevent polypharmacy. Now, before even deciding, you have to know what polypharmacy is. Polypharmacy is basically you have a patient who's on multiple medications. They can't explain to you what they're taking the medications for. Some of the medications have been DC'd and the patient never stopped taking them. They had medications that were added, medications that were subtracted, and they just kept all their medicines, and they just take all their medicines because the doctor prescribed it or you as a nurse told them to take it, and they just never stopped. These are the kind of patients who are at risk for polypharmacy because they can cause some serious adverse effects and side effects to themselves by continuing to take medications that they're not really supposed to take, or they haven't really been educated on how to discontinue or when to discontinue these medications. So this kind of patient, you wouldn't really be looking for medication reconciliation with them, more so as to educating and stopping the medications that they're taking that they shouldn't even be taking, or decreasing dosages, or things of that such. The next thing is conserve financial resources. Medication reconciliation, like I said before, is basically knowing if it's safe to combine certain medications to give to a patient, and making sure the patient is not going to have a reaction. So understanding the financial resources is not really a concern of mine, so I would omit the option B. Now, C says to prevent interactions. That is something that does sound like medication reconciliation would be the correct option for, because you're reconciling medications to make sure that the patient doesn't have any sort of an adverse reaction to the medication that would be undesirable to them. So I'm going to hold on to that option, but I'm also going to look at D. And D says to prevent allergies. Now, there isn't really a way to prevent allergies. The only way that we can avoid, I would like to use that word, avoid allergies, is by giving the patient the medication. You're not going to know if someone is allergic to a medication unless the patient has taken it and they have had a reaction. A lot of times I'll hear patients say, well, I can't have penicillin because my mom is allergic to penicillin. Your mom is allergic to penicillin. You're not allergic to penicillin. We would never know if you are actually allergic to penicillin or any other drug unless you've tried it and you've had a reaction. So allergies, we can't prevent allergies. We can only try to avoid another reaction after having one. Conserving financial resources is not a correct answer, because I'm not concerned about your financial resources when I want to know if a medication is going to be reconciled. And also preventing polypharmacy would be more so of controlling the amount and the kinds of medications that a patient is taking to avoid adverse reactions or unpleasant side effects to taking too many medications. So I think the best option that we would go with would be C. You want to prevent any interactions of drugs that should not be combined and given to a patient. You want to avoid any unpleasant side effects and any unpleasant reactions to medications. So the best option would be to prevent interactions. You want to prevent any unpleasant interaction or adverse effects that could happen to the patient if they were given two medications at one time that they shouldn't be given because they're not compatible together. So the best option would be C, prevent interactions. All right, now number 4, the question is, your pregnant client has a new order for a medication. What principle should you apply to this new medication? Now you have a pregnant patient that has come into the hospital and the patient has a new order for a medication. You as the nurse, what should be the first thing you're looking at when you have a pregnant patient who has now been given a new medication? Now, for educational purposes, if you don't know, all pregnant women are put on drugs that are all pregnant women that are put on medications. Each drug is under a certain classification for pregnancy, right? So we have certain medications that can be given that you might want to think about giving that are on the side, on the air of caution, and that completely cannot be given at all. And these classifications, they are grouped by lettering, and the lettering is class A, B, C, D, and X. Those are the only classifications. A means it's safe to give. B, it's safe to give because there's really no research that is conflicting as to whether or not you can or you cannot give it, so it is a safe medication to give. C is there are some contraindications, so that's kind of a medication where the risk outweighs, or the benefits outweigh the risks. So even though these medications can cause some potential harm to the baby, it would be imperative to give that medication for the safety of the mother that is carrying the child. So that you kind of have to do a lot of thinking and a lot of weighing of your options before you want to give a medication in a C classification. D and X, you just don't want to give, because D and X are not safe to administer to a woman who is with child and carrying a fetus. So those are medications that you really want to stay away from. So now back to the question. Your pregnant client has a new order for a medication. What principle should you apply to this new medication? Exactly what I said. What classification does this medication fall under? A says the fact that drugs classified as C, D, and X are contraindicated. That is true. But we also want to look at the rest. B says the fact that drugs classified as A, B, and C are contraindicated for women who are pregnant is not correct, because A and B we know we can give. So we'll take B out. C is the fact that drugs classified as C, D, and E are contraindicated. There's no E, so we can omit that. And D is the fact that drugs classified as C, D, and Z are contraindicated for women who are pregnant. There's no Z, we stop at X. A, B, C, D, and X. So it's safe to say that option A is the correct answer. The fact that drugs classified as C, D, and X are contraindicated for women who are pregnant. A would be the correct answer. And now we have question 5. Question 5 says, you will be administering packed red blood cells to your client. Which of the following principles should you apply to this blood administration? So there's a lot of rules when it comes to hanging blood, a lot of tedious and strategic planning when it comes to administering blood that you have to know as the nurse. And that is basically how you're going to be able to pull the answer out of this question. It's literally a correct or incorrect answer, and you just have to pay attention to the details so that you know which answer is correct and which answer is incorrect. So we'll look at A. A says you must ensure that the client has a patent intravenous catheter that is at least a 20 gauge. So we know that the patient has to have a patent intravenous catheter. 20 gauge I'm not too sure about yet, so I'm going to hold on to it and go to the next option. You will need the help of another nurse prior to administration of these packed red blood cells. That is 100% true. So I'm going to hold on to that option and go on to the next question. The unit of packed red blood cells should start no more than an hour after it's picked up. We'll come back to that. D says you must remain with and monitor the client for at least 30 minutes after the transfusion begins. You do need to stay with the client, but I'm just not too sure. I'm going to come back to that 30 minutes. What am I going to take out of here that makes absolutely no sense? I think, based off of my knowledge, that the unit of packed red blood cells should start no more than 1 hour after it's picked up. That's completely incorrect. If I had to choose one that I would just throw in the trash, it would be that one, because once that blood is handed to you and it's placed in your hand by the blood bank, you only have 30 minutes. You have 30 minutes to get that blood started. If blood is not started within 30 minutes of you receiving the blood, you cannot hang that blood. So it's safe to say that C is not an option that we're going to go with. The next one I'm going to look at, I want to look at D. D says you must remain with and monitor the client for at least 30 minutes after starting the transfusion. The timing is just off. You want to stay with your client for about 15 minutes after you have started the blood. And that 15 minutes, you're going to be doing vital signs. Once the vital signs are within normal limits and your patient doesn't look like they're having any sort of adverse reactions to receiving the blood, 15 minutes is usually the rule of thumb as to how long you have to stay with your patient once you start hanging blood on that patient. Now we're left with A and B. A says you must ensure that the client has a patent intravenous catheter that is at least 20 gauge. Patent intravenous catheter is where you may be thrown off, as well as that 20 gauge. 20 gauge used to be the correct gauge IV that we needed for hanging packed red blood cells. The main reasoning for ensuring that you have the correct gauge is you want to make sure that it is a large enough gauge and it's patent enough for red blood cells to go through that catheter. If the catheter is not large enough for the red blood cells to go through, you can actually destroy the red blood cells, which would actually make the patient not getting the blood be efficient. So you want to make sure that the catheter is large enough to where the red blood cells are able to go through, as well as go through that filtered tubing, that filtered line that the red blood cells are going to go through. So 20 gauge is not really correct, because studies have shown now that you want to have at least an 18 gauge catheter, a patent 18 gauge catheter when you are hanging blood on a patient. So that's where they try to trip you up at. Yes, you want the catheter to be patent, but you do want it to be an 18 gauge. Hanging blood after an hour, you most definitely cannot do that. So that's wrong. Staying with the patient is important, but it's not 30 minutes, it's 15 minutes. So the best option would be you have to have another nurse with you before you even decide to start with your IV fluids, to start with your normal saline, before you even start making sure IVs are all of that. Before you can even connect that patient to the blood, before you can even administer the blood, you will need the help of another nurse prior to the administration of packed red blood cells. And they tried to trip you up in this answer by saying you need help from another nurse to help you hang the blood, and that's not even what it is. You need another nurse to consent that the blood that you have collected is correct, that the patient is correct, that the information on that bag of blood is correct. You need 2 identifiers. You're not even allowed to hang blood unless you have had a second identifier in the room with you that confirms that the information that's on the bag matches the patient that is going to be receiving the blood. So before you even do any of this other stuff, even if you don't know the answer or the time frame as to which blood is supposed to be administered, or vital signs, how long you stay with the patient, you automatically know you can't do A, C, or D. without having another nurse in the room with you, because you can't connect the blood to the patient unless there has been another nurse in the room to confirm that what you are hanging is correct and that you are giving it to the correct patient. All right, so that concludes the question and answer and rationale portion of this video. I hope you guys enjoyed the questions that we have gone over. Moving forward, I will probably be doing, like I said, anywhere between 5 to 7 questions, depending on how long it takes me to discuss the rationale of the answers with you. If you enjoyed the video, please make sure to like, comment, and subscribe below on my channel. And if you would like to schedule any one-on-one tutoring sessions with me, you enjoyed what you saw, just wasn't enough, you feel like you want some time with me, that is an option that can be discussed. But expect to see more videos, expect to see more breakdown of the questions and the answers, and expect to see more rationales. You guys have heard critical thinking and rationales. I can't say it enough. So you're going to hear it at least 50 times throughout the 5 minutes or 10-minute videos that I do present. And if there are 20-minute videos, you can imagine how many times you're going to hear critical thinking and rationalization from me. So stay tuned for more videos. I hope you guys enjoyed it and expect to see more. Bye.